Good afternoon. Uh, I'm Dr. Vanita. I noticed Dr. Devya signed in. Welcome, doctor. Then we'll guide you into when to sign in. And after,
Good evening.
hi, doctor. Uh, yeah, I'm Dr. Vanita. We have been collaborating over the WhatsApp. Yeah. So I will just wait for it's 4 o'clock. We will have a preliminary discussion with the IAP dignitaries if there are some joining. After that, we'll get started, doctor.
Yeah, sure, definitely.
I'll just check if Dr. Mariam is also around. And I'll send a reminder to Dr. Mariam, and then I'll just be back with you all. Anybody from IAP joining, Mr. Sanz? Hi, Dr. Marian. Let me introduce you to Dr. Divya. She's your co-speaker today. Dr. Divya, that's Dr. Mariam. She's also joined in. I'm just waiting for uh, any of IAP dignitaries to join and to do the formalities. Probably Dr. Anjan will be joining in, and I'll just get started when it's 4 o'clock. Good evening, everyone. Warm welcome to you all. Uh, this is the 10th session of IAP AMH webinar series. For those of you who are joining in first time, a brief introduction. I am Dr. Vanita. I'll be your host and moderator for today's discussion. We have monthly sessions of pediatric subspecialty CMEs from speakers from IAP contributing to major subspecialty expertise. And we usually plan a speaker from Bahrain to complement local perspectives. This is how our webinars are planned, ranging from pediatric endocrinology to pediatric gastroenterology. We have covered various subspecialties in the last year. We have reached the annual anniversary timing also. By January, we are planning on a first year anniversary pediatric CME session also. In the meanwhile, I will have to thank Dr. Basavaraj, who's been the IAP president who championed the cause of this CME, and Dr. Neelam, who is the president-elect who has been behind all the sessions. I was told that they have traveled to UK and probably currently unavailable. And the man behind the whole conceptualization of CME, Dr. Ranjan Pejawar, would possibly join. And when he joins, we'll have a forward from him as well. Today's theme is our pediatric dermatology, and we have two eminent dermatologists from their part of practice to cover two common pediatric encounters. Very ingeniously titled, first title, fever with rash. It's an encounter every pediatrician uh, goes through. And it can range between something as a common encounter, which has to be distinguished from something of serious red flagging, which we will see today from the first speaker's presentation. And the second common presentation that every pediatrician encounters is atopic dermatitis. We will see the common uh, perspectives in this arena, and we'll have a discussion from both the dermatologists after this session. So I did not see Dr. Ranjan Hinden. I think we will get started with our session as it's time. We will have a 1 hour session from both the speakers, half an hour each, after which we'll have a discussion. In the meanwhile, if Dr. Ranjan joins in, we will have his forward as well. So first speaker is Dr. Divya Gupta. She is a dermatologist from India, currently practicing in Manipal, Bangalore. Manipal Hospital, Bangalore. She has a very rich background of dermatology. Currently, she is an editor, which is a subsect of pediatric dermatology in Indian Journal of Dermatology and Venereology. We are privileged to have Dr. Divya Gupta chairing today's session. Dr. Yogesh, I notice you around. Can you please give our forward before we get started, before I hand over the mic to Dr. Divya Gupta? Dr. Yogesh, can we have you?
Yeah, good evening all, and Dr. Vanita and Dr. Mohammed and all. Welcome to this our partnership with the Bahrain branch of the IAP and Mission Hospital and Dr. Divya Gupta, Dr. Mariam. Uh, Let us start the academics because people are waiting for the academics for both our experts. So thank you very much, and over to Dr. Vanita. Please carry on.
Thank you, Dr. Yogesh. Dr. Divya Gupta, can you please take over? We will have a discussion after your presentation, Doctor. Dr. Divya, please join in.
Thank you so much, Dr. Vanita and Dr. Yogesh Parekh. And at the outset, I would like to thank the Indian Academy of Pediatrics for letting me share my experience with you, and also to Dr. Ranjan Pejawar, who brought me on board for this. I'm just going to start sharing my screen now. Is it visible? Is my screen visible?
Yes, Doctor.
Yes.
Okay.
Please make, yes, okay, good.
So a very good evening to all of you. I have chosen this topic of fever with rash in a child because, as Dr. Vanita mentioned, it is something that we see very commonly in our OPDs, both by pediatricians as well as dermatologists. And this is something where, you know, it can come into your OPD or it can even come into your emergency room. Okay. So I will be talking in my presentation. I mean, of course, there's a lot to discuss, but I will just be giving my approach, which over the years I have sort of, refined, and a few points clinically which helped me to arrive at a diagnosis. And I will be sharing that today with you. So when we talk about fever with rash, or what we call commonly an exanthem, now this word is derived from the Greek word called anthos. Okay, anthos means bloom. And a flower blooming is just like a rash erupting. Okay, so when you have a rash with various systemic symptoms like fever, malaise, headache, okay, that is what we call an exanthem. Now, if you look at most of these, your textbooks and articles on fever with rash, you know, you'll have a very sort of a very theoretical kind of etiology-based classification. Like, for example, viral, you have measles, rubella, you can have parvovirus, EBV, CMV, varicella, rotavirus, so many. Bacterial, like various toxin-mediated syndromes. Mycoplasma pneumoniae, rickettsia. And of course, then there are non-infectious causes like drug rash, connective tissue disorders, and other conditions like Kawasaki, graft versus host disease, autoinflammatory syndromes. It's good to know this etiology-based classification, but when you are actually there in front of the patient in the OPD or in the ER, sometimes it's not very easy to sort of recall this or sort of put the patient in these categories. So here, what helps to a case of fever with rash is having a structured approach. Okay, so the things that we typically look at is, number one, what is the pattern of rash? What is the morphology? What is the distribution? What is the duration and chronology? When did it begin and how did it progress? Okay, are there any systemic symptoms which are associated with it? Is there any mucosal involvement, organ dysfunction, and are there any risk factors? Like, for example, what is the age of the child? Certain rashes are more prone in younger age groups. Some rashes are seen in older children. Is there any history of travel, exposure? What is the immunization status of the child? So these are some of the broad things, pointers that we look at. So coming first to morphology. Now, this is without doubt one of the most important things that a dermatologist would like to look at. Okay. Now, a maculopapular rash, typically, broadly speaking, it could either be infectious in origin or it could be drug-related. So common infections would be most likely they would be viral. You have measles, rubella, dengue, chikungunya, okay, adenoviral infections, but they could also be bacterial. They could be rickettsia, okay, connective tissue disorders, drug rashes. Now, petechial or purpuric rashes. For any dermatologist, any kind of petechial or purpuric rash is a red flag sign because invariably they signify some kind of a serious etiology. Like, for example, meningococcemia. It could be leptospirosis. It could even be serious forms of dengue, rickettsia. It could be vasculitis, okay? Or it could be something even more sinister, like a leukemia or purpura fulminans, okay? Or some very rare causes like Langerhans histiocytosis. Usually they will be more serious. The child will be sick. And if not diagnosed in time, they can have serious consequences. The other thing that we look at is vesicular bullous. Now, thankfully, there are not too many conditions which present with the vesicular bullous morphology. Okay, sudden onset vesicles, distributed all over the body. You would think of varicella. If it's over hand and feet, you would think of hand-foot-mouth disease. Okay, or sometimes if there are large bullae, you would think of an SJS 10, staphylococcal scalded skin syndrome, or even a bullous impetigo. Urticaria. These are some of the most common morphological forms of rashes which we see in our practice. Okay. Now, urticaria in children, typically what I remember is 5 I's. Okay. So infection, inhalation, ingestion. So it could be viral, food, stings, vaccines, drugs, or serum sickness. And then the other serious category of rash would be desquamative or exfoliative. Under this, you have Kawasaki, scarlet fever, and toxic shock syndrome. Now, the next thing that we look at is how did the rash progress? So first we looked at morphology, next is progression. Centripetal, if it starts at the periphery and then comes towards the trunk, then we are looking at something like a Rocky Mountain spotted fever. If it's centrifugal, that it starts over the trunk or the center part of the body and then it spreads out, then we are looking at some other forms of rickettsia, even scarlet fever, rotavirus, toxic shock syndrome. Cephalocaudal is very, very typical of measles and rubella. Typically it starts on the head and then progresses to the toe and it disappears in the same order that it starts. If there is a mucosal involvement, you think of SJST and mycoplasma-related rash or SLE. And acral rashes, okay, some rashes are very, very typically, they have acral involvement, like you have your hand-foot-mouth disease, you have erythema multiforme, and then of course you can have Kawasaki and scarlet fever, where there can be periungual desquamation and swelling of hands and feet. Now, the other thing that we would like to look at is the timeline of the rash evolution. Okay, so typically measles and rubella, they have a similar timeline, except that rubella progresses a little faster. So for example, in measles, you have fever and constitutional symptom. The rash starts on day 4, it resolves by 14 days. And typically, as I mentioned earlier, it goes in a cephalocaudal spread. Rubella, same thing, except that the whole thing is over in 7 days. Parvovirus infection, also known as fifth disease, is very, very characteristic slab cheek appearance. Okay, so you will have low-grade fever. The rash will appear on day 2 or day 3. and the whole thing will fade away by day 6. Okay, and after that, you will have a lacy reticular kind of pattern on the trunk, which will fade away a little slowly. EBV, the most characteristic is post-antibiotic rash. Now, this can be very tricky because many times children will come to us with history of fever, and then the parents will take them to a clinic where they will receive some kind of a, like a crocin, a paracetamol syrup, maybe a broad-spectrum antibiotic, and then post that, the rash will start. So one is not really very sure whether it is the infection that caused the rash or whether it is a drug that caused the rash. And many times these are misdiagnosed as drug rashes. But it could also be an EBV-associated post-antibiotic rash. Okay, so this is typically seen on day 7 to day 10, and this is something that can also be seen with CMV infections. Exanthem subitum, it's very common in young children, very mild fever, rash, and the whole thing is over in about 5 days. Okay. Enterovirus, rotaviruses, again, HFMD, enterovirus called hand, foot, mouth disease. They are very, very typical, very characteristic. Most of us are able to diagnose. Although it says hand, foot, and mouth, most of the times we also see rash on the elbows, knees, buttocks, and many times the rashes also come on the face. Now, there can be sometimes atypical presentations of hand, foot, mouth disease with hemorrhagic lesions or target out lesions, but they are an exception rather than the rule. Rotavirus associated rash often associated with diarrhea and fever. Dengue and varicella, of course, they are quite common, and varicella is associated with the characteristic dewdrop appearance the dewdrop on a rose petal appearance, and again, the whole rash disappears by 14 days. Now, age-wise differential diagnosis, this is also important to remember. There are certain conditions which present very early in life, like for example, neonatal herpes simplex, listeria, Langerhans cell histiocytosis, okay, or congenital CMV infection. They will typically present very early in life, within the first 1 or 2 months of life. Okay. Then you have infants and toddlers, exanthem subitum, hand, foot, mouth, rotavirus, EBV. EBV, CMV are usually asymptomatic infections in most of the immunocompetent children, and we will not even know that they have been infected. Then, of course, papillary ectodermatitis of childhood, also known as genetic prosty, Kawasaki. These are all, they are seen in less than 5 years of age, and we should not be suspecting these things in older children. Older children, what often we see, especially 9 to 10 years age, adolescents, connective tissue disorders, rickettsial infections, scarlet fever. Okay, in unvaccinated, typically measles and rubella outbreaks occur between 5 to 10 years of age in children who are not vaccinated with the MMR vaccine. And then there are certain infections which can be seen irrespective of age across all age groups. So here you have staphylococcal scattered skin syndrome, varicella in unvaccinated children, dengue, drug reactions, meningococcemia, SJST and malignancy, and rarely the MISC. Now, systemic symptoms also, now this is important to remember. Usually fever is present in all the acute infections, but sometimes if the fever is, if it is chronic, if it is long lasting, then one should think of connective tissue disorders or malignancy. If there is an associated upper respiratory tract infection, then think of viruses or bacteria. Joint pains, again, some infections like chikungunya and dengue, or even connective tissue disorders like SLE, juvenile idiopathic arthritis, vasculitis can also associated with joint pains. And then, of course, serum sickness-like reactions. Now, there are certain conditions which may be associated with hepatosplenomegaly and lymphadenopathy. Now, depending on the pattern of lymphadenopathy, if it is generalized, you can think of infectious mononucleosis, EBV, CMV, even severe cases of measles, leukemias, drug hypersensitivity. But then localized forms of lymphadenopathy may signify something else. Like, for example, occipital lymphadenopathy you see only in rubella. You do not see generalized lymphadenopathy there. So presence or absence of hepatosplenomegaly and the pattern of lymphadenopathy also gives you a clue regarding to the etiology of fever with rash. And then, of course, if there is, if there are other more serious signs and symptoms, if there's multi-organ failure, shock, then we are thinking of something like dengue, dengue shock syndrome, meningococcemia, leptospira, drug hypersensitivity, and other things. So as a dermatologist, certain red flags that we always look for and that always requires us to consult our pediatric colleagues. If the child has fever with rash, with toxic look, altered sensorium, if there are presence of mucosal erosions, if there is rapid progression, certain morphologies like petechiae purpura, if there is hypotension, cold peripheries, If child is not responding to antipyretics and if there is multi-system involvement, then definitely the child has to be referred, and it can indicate an urgent dermatosis or a life-threatening condition. Now, this is a busy slide. I do not expect you to sort of go through each point in this. Basically, this is taken from one of our, chief textbooks called Bologna. So basically, it says that, depending on the pattern of spread, morphology, okay, presence or absence of enanthem, that means presence of mucosal spots like Koplik spots or Nagayama spots or Fosheimer spots, pattern of lymphadenopathy, presence or absence of joint pain, okay, presence or absence of ocular symptoms like conjunctivitis or enlargement of liver, spleen, encephalitis, seizures, meningitis, pneumonia, myocarditis. These all presence or absence of these could be pointers to various viral exanthems like measles, rubella, herpes virus, Epstein-Barr, adenovirus, enterovirus, and so on and so forth. Okay. So these are some of the things that we keep in mind during history taking. Okay, when did the rash start? When did the fever start? How did it spread? Okay, what does it look like? Are there macules, papules, vesicles? Okay, are there any associated symptoms? Is there any travel history? Is there any contact with sick individuals, animals, any potential allergens, focus of infection, any history of recent drug intake, including over-the-counter drugs or traditional or alternative medicines like Ayurveda, Unani, homeopathy? Okay, whether the child is immunized for vaccine-preventable diseases, and is there any underlying condition like immunodeficiency, any autoimmune disorder, or any family history of other relevant illnesses. Okay, on examination, always check for temperature, heart rate, respiratory rate, blood pressure. Okay, for a dermatological examination, we do a detailed assessment, including the morphology, distribution. For rickettsia, always look for a tick bite or eschar, and always look for skin tenderness. Skin tenderness can be a very important pointer for certain conditions like SJS-TEN or even staphylococcal scalded skin syndrome. So it's important to just put your hand there and see whether the skin is tender or not. Okay. Bedside tests like Nikolsky sign, we'll see in some examples a few slides from now. Especially false Nikolsky sign can be positive in SJS-TEN. Okay, diascopy to distinguish between purpuric rashes and macular rashes. Sometimes there may be an overlap, like in cases of urticarial vasculitis. It looks like urticaria, also looks like vasculitis. You just put a glass slide and see whether the rash blanches or not. If it is not blanching, then there is an underlying component of purpura that is there, and that rash requires a biopsy. Okay. Never forget ever to examine the mucosae, palms, soles, nails, and scalp, because often there are important clues over there that we end up missing out. Okay. Always look for pattern of lymphadenopathy, and always check for signs of other organ involvement like jaundice, hepatosplenomegaly, and look for any neurological changes. Lab tests, we do basic CBC, CRP, ESR. Now for infectious causes, PCR and serology testing is available for most of the infections. Okay. If purpura or bleeding is present, always ask for coagulation studies. Blood cultures, I believe, are no longer done, or they are sometimes delayed. So a procal level can be very informative. As a dermatologist, something that we would always suggest would be a Zank smear. Okay, especially in herpes simplex infection, varicella, and also skin biopsy to rule out any kind of vasculitis or other things which can be diagnosed on a biopsy. Okay, and never hesitate to ask for any kind of cross consultations. So through the next few slides, I'll just be taking you through some of the examples of cases that I came across in my practice. So this was a 15-year-old male child with high-grade fever since 5 days. Platelets were 33,000, and the NS1 antigen was positive. And what you see in the picture is basically, islands of sparing, which are typically described in dengue fever. Okay. Now, this is the second case. 5-month-old boy with fever. He was given paracetamol and syrup amoxicillin, and he developed generalized rash 5 to 6 days later. Cervical lymphadenopathy was present, and otherwise the child was well and completely asymptomatic. Okay. A peripheral smear revealed lymphocytosis. EBV IgM was positive. This was an EBV ampicillin-associated rash, and as I mentioned earlier, these cases are often confused with a drug rash. Another case, 7-year-old male child with fever, headache, vomiting. There was a history of fall from height 2 weeks ago, followed by mobiliform rash on day 2, and days formation began on day 5. Okay, cervical lymphadenopathy was present. Procalcitonin CRP levels were raised, MRI revealed osteomyelitis of femur, and blood culture revealed heavy growth of MRSA. This was a case of staphylococcal scalded skin syndrome. You can make out the typical disc formation over palms and soles, which started by week 2. Now, here I want to draw your attention to 2 or 3 conditions which often show overlapping features and which can be quite confusing. So those are toxic shock syndrome, scarlet fever, and Kawasaki disease, because they are all characterized by fever, mobiliform eruption, followed by disc formation and a strawberry tongue. Okay, so in many of these things, the differentiation can be quite difficult. And we can also add a drug rash to this list. And differentiation can be quite difficult, but there are certain clues which can help us. Like, for example, Kawasaki disease shows thrombocytosis, whereas a TSS will usually show thrombocytopenia. Kawasaki, you will not usually get a multi-organ dysfunction or any hypotension or diarrhea, whereas that can be present in toxic shock syndrome. Okay, disc formation usually starts much later in Kawasaki disease, whereas it starts much earlier in scarlet fever. So these are some small pointers which can help us differentiate. And as I mentioned earlier, of course, there are now serologies and PCRs which are available, which can help us pick up any kind of infectious etiology behind a toxic shock syndrome, like a streptococcal or a staphylococcal infection. So for maculopapular eruptions, apart from viral causes, scarlet fever, Kawasaki, toxic shock, and drug eruption, these 4 are important 4 causes of fever with rash, which we should never miss out. And drug eruptions of these, they are often polymorphic in nature. Polymorphic means it can present as a maculopapular rash, it can present with a papular rash, vesicles, hemorrhagic rash, okay? It can present as anything. And that's why it's very important to have a good history and examination and keep a keen eye out for drug eruptions. Some pointers to differentiate drug eruptions from other things would be eosinophilia is often quite marked in drug eruptions. But again, that is not always the case, because in DHS, sometimes you can have eosinopenia as well. But then generalized lymphadenopathy, a significant facial edema, these are some small pointers which can help differentiate drug eruptions from other causes of fever with rash. So this is the criteria for Kawasaki disease. I'm not going to go into detail of this. Now coming to the third case scenario, petechial exanthem. This was a 1.5-year-old male child with high-grade fever, vomiting, altered sensorium, and toxic look. A lumbar puncture revealed gram-negative diplococci on gram stain. This was a classic case of meningococcemia. Now, again, for hemorrhagic or purpuric rashes, important things that we should keep in mind are atypical measles, hemorrhagic fevers, congenital CMV, rubella, toxoplasmosis. Rickettsial infections are the ones which we see most commonly in our practice, but once in a while we get other things also, including meningococcemia. Vesicular exanthem, another case, 13-day-old child, came with fever, managed as sepsis with IV antibiotics. He developed bilious aspirate. On day 3 of admission, antibiotics were given, but there was no improvement. CRP was positive. History of convulsions was there. And on day 5, he developed these typical vesicular lesions all over the body. And this was an example of neonatal herpes simplex infection. Okay. Now, herpes or eczema herpeticum is something which we can also see in very severe atopic dermatitis. They often come with sudden worsening of their eczema, fever, toxic look, and many times you actually don't see vesicles. You just see these kind of tiny excoriations all over the body. Okay, so this is a clue for eczema herpeticum, okay, or Kaposi's eruption. Now, rash with mucosal involvement, I have been called many times to give opinion. Now, look at this girl. She's a 9-year-old girl with this kind of hemorrhagic rash on the lips. Okay, most of the times these are diagnosed as SJS or EMF major. But I wish to draw your attention to these tiny vesicles. I've marked them with yellow arrows, which are present on the upper lip and also on the corner of the lips. Okay, and this is another example of the same. Okay, as you can see, this in this blue arrow, can you see some erosions? Okay, they have polycyclic margins. So important to keep in mind that this kind of hemorrhagic crust with severe intraoral erosions in young children, especially look for presence of erosions with polycyclic margins or vesicles on the lips, because you can be dealing with a primary episode of herpetic gingival stomatitis and not really an SJS or TN. And many times they are actually mismanaged by giving oral steroids when all the child needs is oral or IV acyclovir. Now, this is very easy to diagnose. Okay, this is obviously a case of toxic epidermal necrolysis. But then look at this girl. She is a 12-year-old girl who presented with significant conjunctival suffusion, necrotic slough on the lips, and all she had on the skin were tiny atypical targets. And the only clue was the small patch on the back where if you did a Nikolsky, the false Nikolsky was positive. Okay, so this was a case of erythema multiforme major. Here it's important to look for target lesions, okay, and check the palms and soles for presence of these lesions. And these can be easily missed. Okay. Now, another case, very typical. This was a 1.5-year-old child. You can see the significant perioral crusting over the eyelids. Even the body folds were tender, erythematous, and showed peeling of the skin. Okay. So this was a case of staphylococcal scattered skin syndrome. Now, these are some important causes of oral ulcers with crusting and fever. As I discussed, primary episode of herpetic gingival stomatitis, RIME, reactive infectious mucocutaneous eruption. This is a recently described entity. EMF major, SJS-TEN, SSSS, it's important to remember that they do not have any intraoral erosions. They only have perioral crusting, which can look very severe, but usually the mucosa itself is normal. And uncommonly, even systemic lupus erythematosus can present with hemorrhagic crusting. So if you see, adolescent girls with this, you can always send an AN. Now, this diagram is again taken from Bologna, and it summarizes very well how to differentiate the rash based on morphology and distribution in Kawasaki disease, staphylococcal scattered skin syndrome, and EMF major and SJS. So in EMF major, SJS-TEN, you will have typical or atypical targets. You will have hemorrhagic crusting of the lips. In staphylococcal scattered skin syndrome, there will be peri-orificial accentuation with radial scale crusts, but actually intraorally, it will be normal. Okay. And in Kawasaki disease, there is just chapped lips or fissures with, very red-looking conjunctiva, but there are actually no erosions per se. Urticarial rash. Now, this is again something which we see extremely commonly, especially in pediatric ER. So this was a 3-year-old child who presented with high-grade fever and sudden eruption of these urticarial rashes. Now, I again wish to draw your attention to the extremities. As you can see, there is swelling of the hands. On the left side, you can see there is this large annular-looking rash with central clearing. Okay, and on the right side, you see there is an atypical target. Okay. So this was an example of and so many times we get a referral saying, is this erythema multiforme? This is not erythema multiforme. This is something called as urticaria multiforme or acute annular urticaria, okay? This is a morphological variant of acute urticaria itself. And here are some clinical pointers to differentiate this condition from urticaria and from EMF. Okay, so urticaria multiforme, urticaria will just have hives. Whereas if you have hives which are arranged in an annular fashion, there is central clearing, acral edema, or sometimes plus minus central ecchymosis, then we are looking at urticaria multiforme. Okay, on the other hand, so at urticaria multiforme doesn't have typical targets. A typical target will have 3 layers: central dusky hue, followed by a rim of, a pale, followed by a rim of erythema. Whereas an atypical target will have only 2 out of 3 rings. Okay, so an EMF will be a typical target, whereas urticaria multiforme will be an atypical target. And in urticaria multiforme, you won't have any skin necrosis, mucous membrane involvement, or any blistering. Now, many times this urticaria multiforme is seen in association with severe systemic features. Okay, so there we are dealing with something called as serum sickness-like reaction. Here, the child will be very sick looking, will have fever, joint pains, abdominal pain, may have fatigue, malaise, weakness, but actually it carries a very good prognosis, and most of them respond very well to systemic corticosteroids and antihistamines. Now, urticarial vasculitis, this is the other condition that can present with, an urticarial looking rash. with fever. But again, some pointers to differentiate from urticaria. A vasculitis will always persist for more than 24 hours. Urticaria will always resolve within 24 hours. Vasculitis always resolves with PIH, and pain is the predominant symptom as opposed to itch. So whenever we have any doubt, we should look at these three things. And if it is present, then possibly we are looking at an urticarial vasculitis. And of course, we should use our glass slide, do a diascopic test. And if the rash is not blanching fully, then we should definitely send it for a skin biopsy with the immunofluorescence. Okay. Now, there are certain other conditions, like for example, this was a 12-year-old child who was retropositive on ART, and he developed these papillary-looking rashes on day 3 of starting the ART treatment. Okay, so this was a case of papillary drug rash secondary to ART. This was another very interesting case, which came 5-year-old boy with steroid-responsive nephrotic syndrome, developed papillosquamous rash in a photodistributed area, and skin biopsy was suggestive of vacuolar interface dermatitis. ANA was strongly positive, and this was one of very rare cases of a lupus in a young male boy. So we sent his sample for sequencing for early complement deficiency, and so this can also present as fever with rash. So that was a quick sort of an overview of my clinical approach to cases of fever with rash. So just to summarize, when we get a case of fever with rash, it's not always as simple as it looks. We should always take into account the morphology, the distribution, the timeline, how it progressed, and whether there are any associated red flag signs to come at a diagnosis. And never hesitate to ask for any cross consultations. Thank you.
Thank you, Dr. Devya. That was an insightful journey across the spectrums of pediatrics, and it was indeed a good walk across presentation. So we will please stay back. We will have the next presentation, and we'll have a discussion after the next presentation. Thank you very much. The next, we will transition from the acute scenarios that pediatricians would encounter in dermatology to a chronic condition. So can we have Dr. Mariam? This will be our second presentation. Dr. Mariam Najab is from...
Yes,
Dr. Mariam, are you around?
Yes, I'm here.
Thank you very much, Dr. Mariam. Yeah. So Dr.
fine.
Mariam is a dermatologist practicing currently in King Ahmed American Mission Hospital as a dermatology consultant. We will have her talk about atopic dermatitis. We pediatricians have heard her talk about atopic dermatitis once before. We would be happy to have her discuss for the benefit of all the audience who joined. Dr.
Thank
Mariam,
you so much,
can we have you
Anita,
start
for the
about...
nice introductions. I'm trying to share my screen.
Yeah, you could share now. In the bottom of the screen, the share green button.
Share, yes, and then I'll press share.
Yes,
I'll have...
you're in, doctor. You'll have to go to your presentation. You're in. You can make it. Yes, thank you.
So I'm really...
The next 30 minutes, we'll hear from Dr. Mariam. Thank you.
Thank you, dear. I would like to thank you all for attending and for giving this nice opportunity to have like a new community contact with. So today I'll talk about the atopic dermatitis in pediatric, and I think this is it's an old field, but with a very lot of recent updates on it. So first I will start my presentations with this case. She was 8 years old. She presented to me in end of February 2024. The patient was no eye contact. She was so depressed. Her mother was also suffering. It's not about the redness. It's not about the scales. It's about the itching. She cannot sleep. She's missing the school a lot of days. And when I saw her, she was recently admitted for the third episode of eczema herpetica. So as you can see, she's having what we call it bathing suit, or not, or we call it the erythrodermic. 90% of her body is covered by eczema. So this is a real suffering for a patient. And at the end, and the patient was worrying also because it was a season of Eid, and the patient was worrying that she cannot wear a nice dress, and she was crying. And after that was in end of February 2024, then it was in April. So the mother then sent me a picture that she was so happy, and patients enjoyed her Eid. So I'll tell you about later what I kept her on. But I think this is a miracle. This is not something that you can reach with only topical therapy. So what is atopic dermatitis? Atopic dermatitis is a chronic pruritic inflammatory skin disease that is commonly affected the children and the adults. And it's often associated with elevated IgE, but this is not necessarily related to the severity of the atopic dermatitis. And it can happen also as an allergic mark, which is a group of disease like eczema, asthma, rhinitis. What is the prevalence of atopic dermatitis? The prevalence is that we have approximately 5 to 20% to affect the children worldwide. And usually we see it, 85% we see it before the age of 5 years old. And 80% even before the age of 1 year old. And we have some slightly female predominance affecting with atopic dermatitis. And persistent atopic dermatitis beyond the infancy may affect approximately 50% of the patient who's diagnosed with atopic dermatitis during the childhood. So why it happened? What is the risk factor to get atopic dermatitis? So usually it's a mix of genetic and environment. And the most important gene that's affected in atopic dermatitis is the FLG genes, which is encoded for the filaggrin. Filaggrin is a molecule that is important for the natural moisturizing factor in the stratum cornea, which is the superficial layer of the epidermis. So if we are missing this gene, or the gene is not working very well, so we have the first step of the pathogenesis of the eczema, which is the dryness, the xerosis. These are other genetic factors also noticed and published that can cause or predeposit for the atopic dermatitis. So this is the genetic. So what about the environment? Environment is we are talking about the a climate, urban status versus rural. If we have exposing to the microorganism, water hardness, pollution, name it, anything that can affect our environment can also affect our inside body, especially even I can add with the stress. So what is the pathophysiology? Usually if we have genetic factors which we cannot change, then we have something, as I told you, we missed the filaggrin, then we have a problem. Okay, then we have a problem with the epidermal barrier dysfunction, which can cause the immune dysregulations, and then will cause also neuroimmune interactions and the alterations of the cutaneous microbiome. And as you can see in this picture, it's very complicated, but in these pictures, it gives us hope. Because when we really understand what psoriasis means, what's the molecule increase, what the molecule are inhibited to help the patients with atopic dermatitis. And you can see the smaller pictures here, as you can see the corneum cell, which is the superficial skin cell. It's in the normal skin, it gives us very hard, nice wall, because I can always imagine it like a block. When you want to build a wall, you have to put a block, and between the block, you have to keep a cement. So that will give us the rigidity of the wall. So if we don't have this cement in between, so we will have very fragile, weak wall. So that's exactly how I explain the condition for the patient. So if I have the eczema skin, I have very fragile wall. So no moisturizing, no lipid, no ceramide, no fatty acid between the cells. So it's easy to get cracks, easy to microorganism to get inside. And then there is like a secondary immune system coming down, the inflammatory cell. And here is where the pruritus or itch cycle will present. So what is the pathology? So now these are all in theory. So what is in the real eczema patients? If we take a skin biopsy, we will see some changes in the superficial and the mid epidermal layer. There is like spongiosis. There is sometimes even there is like a vesicular. There is some water edema in the supraepidermal. So maybe this is something with the histopathology, more complicated like a path, but I'd like to mention it here. What is the clinical manifestation of eczema? All of us, we know that there is a redness, there is an itching, there is like a small maybe papule or vesicles. It's usually in the anticuticle fossa and in the popliteal fossa. The major thing that you have to know that there is a primary skin lesion, there is secondary skin changes. The secondary skin changes, usually we see it like excoriation, the scratch mark, or we can see the lignifications. You see the difference between the colors in the also Fitzpatrick skin color. Like in the white Fitzpatrick, or like Fitzpatrick type 1, 2, 3 will present as a red erythema, while in the 5 and 6 Fitzpatrick skin will show like a brownish. And that also can give us sometimes a challenging in diagnosis the case. Here, very important is that we know the distributions of the disease. Usually in the infants, which is from the birth to till 2 years of age, we see it mainly in the face, on the cheek, and we can see it also in the extensor, in the elbow, from back, from the knee. And when the child becomes more than 2 years, he will develop it in the flexure area and in the neck. These are the most common. So if you can see to the pictures B, you can see that a baby that you don't understand anything in life is just crying, irritable, and start to scratch, or he rub himself on the bed. That is how severe is the pruritus of the eczema. Maybe the color, it's not bothering the baby. The redness is not bothering the baby, but the symptoms itself is the problem here. So you can see him, he is not sleeping nighttime. He's irritable, crying. You don't know how to act with him. So this type or this age group, they need to educate not for the baby, they need to educate the family regarding these diseases. And the other row, this is the second row, is the manifestations of the other age. You can see it in the flexural area. So here we have Rajika, we have the Hanifin-Rajika criteria regarding the atopic dermatitis. We have the major criteria and we have the minor criteria. So if you have 3 out of 4 of the major criteria, so you are talking right. So we are talking about the pruritus, we are talking about the morphology and the distributions, and about the chronic relapsing dermatitis family history. So yesterday I saw a patient in the clinic. She was 8 years old and was first presentation for her. I was telling the parent that she had an atopic dermatitis. They are denying and they are like not happy. So I was insisting to sit with them and exactly understand why they are not convinced about the diagnosis. So they told me, it's because we don't have an eczema before. This is first time happening to her. She's 8 years old. It should be at the birth. So I told them, since she have it in the morphology, distributions, pruritus, and the father mentioned that he has rhinitis. So I told him, so you have the predisposition to get the atopic dermatitis. And she have also was xerosis. So this is a minor criteria of the diagnostic features. Here some pictures of the minor criteria. We also face it a lot in our clinic. Sometimes xerosis, only dryness, sometimes cheilitis, sometimes pityriasis alba, and usually that will, most of the patients will come to me in the after summer vacations, after went to the swimming pool, exposed to a lot of sun, they will come because the normals can get tan. So the dry patches will become more obvious. Denny Morgan fold around the eyes, we call it the shiner sign also around the eyes. That is also can give us that this patient has an eczema. And in the last pictures here, you can see how thick the brownish scale, and this is what we call ichthyosis. So there is a difference between xerosis and ichthyosis. And ichthyosis vulgaris is a minor criteria of atopic dermatitis. Again, what is the other associated finding? We can see the hyperlinearity palms. So when you ask the patient, just show me your palms, you will see like hyperlinearity in their palms. Keratosis pilaris, the pumpiness, the roughness, especially in the shoulders, in the upper thighs, patients also will complain of. There is some morphological variant of the eczema. We have the lamellar or discoid eczema. We have the prurigo nodularis. Usually we see it in the adult age, but if the patient will have like a severe itching, we can see prurigo nodularis and the follicular types, which we see it a lot in pediatric age group. Is there any lab test I have to do it for a patient? Actually, there is none. No, it's not using as a routine, but if it will just give you like an evidence. You will have like high IgE with eosinophilia. This is the most important. Or if you want to do like a skin biopsy to rule out other diseases, or you are thinking of multiple differential diagnosis, then you can go for the skin biopsy, but it's not like routinely done for the atopic dermatitis. What is the clinical course? Usually it's a chronic diseases. Most of the patients at the end of the childhood or beginning of the adolescence, they will improve, they will cure from the atopic dermatitis, but it is a disease that can persist to the adulthood. What is the complications? As I told you, because it's really, we have damage in the skin barrier, so it's easy to get an infection. So colonization of Staph aureus, and nowadays, I'm seeing a lot of MRSA positive patients. Herpes simplex viral, eczema herpeticum, we call it another name, Kaposi vericiform. We have atypical hand, foot, mouth diseases. So if the patients have atopic dermatitis and he has like episode of hand, foot, mouth disease, you will see like hemorrhagical vesicles around the limbs. So this is what we call it eczema quasicum. And molluscum contagiosum is one of the most infections affecting this age group. So what is the differential diagnosis for atopic dermatitis? If you see atopic dermatitis, what do you think about it? So allergic irritant contact dermatitis, especially in the diaper area. Let us to put something in our mind that usually atopic dermatitis will not give us at nappy rash. Usually it's the nappy rash will cause with allergic or irritant contact dermatitis. The seborrheic dermatitis, you can see seborrheic dermatitis also sometimes its border is red. There's some minimal scales. It can affect the scalp, because the cranial scalp. It can affect any other like a seborrheic area in the body. Then we have the psoriasis, the major differential diagnosis. Sometimes it's difficult even to differentiate between either atopic or it is psoriasis. And the scabies, the bigger mimicker, anything, and name any diseases and put the scabies as a differential diagnosis. And we have here two more differential diagnoses, like the one on the left side, around the mouth. This is like the zinc deficiency. And the one in the right side, we have the Netherton syndrome, which has also the atopy and this classic double-walled lesions on the patients. So now if the patients came to you in the clinic, is there any score that would you like to do for him? There is many scores there in the research, but for my side, I believe that these all scores is value for like a research, but in the real time, it's really difficult. So you just go for like mild, moderate, and severe atopic dermatitis. So what is why, if the patients it's coming on and off with refractory diseases, a lot of flare-ups, not responding well to the treatment, be sure one of these things. Is the patient's adherence to the treatment plan or no? Is the medication is right or no? Is there any environmental factors? The patient is exposed to mold, exposed to mites. In our culture we have the bukhur or the fragrance. If the patients have like infections, many patients they have like a lot of dolls around their bed. So you have to be very you have to educate the patient that if this can be like exacerbating the child atopic dermatitis. Is there is like food or environmental allergy, or maybe you are talking about another differential diagnosis. So again, sit with the parents, talk to them, and mention that if the treatment is the regimen is too complex, the mother or the father cannot understand or cannot follow with you. So make it simple for the patients. If you give the patient the medicine, but you did not instruct them, they will take it, but they don't know how to use it. Medication is not used because of the parent or patient's fear of medication side effect. In my clinic, many patients, once I tell them the medicine has a steroid, no, we don't want any steroid for our child. So these patients, you need to sit with them, discuss with them, inform them every single thing about this medicine. So they are, until they convince. So when they go home, they will use. Maybe the medication is not available, and sometimes it happens. I'm writing a prescription for the patients going everywhere to get this, like a moisturizer. He's not using, so he did not find the one that I prescribed, so he's not using any. So, or he get it, but it's high cost. Are not available, as I told you. So these, to be very sure and very clearly discuss with the parent during the visit of atopic dermatitis patients. These are one of the action plan, like it's like a checklist. You can give it to the patient. It's very simple. It's just like you put all your instructions and let the patients to follow. Is there any comorbidities with atopic dermatitis? Yes, there's a lot of comorbidities. Maybe this is like a new era also of the atopic dermatitis. But the most common comorbidities is the allergic contact dermatitis, is the food allergy, is the colonizations of staph aureus, alopecia areata, other autoimmune disease associations. So these cycles like a multiple comorbidities, but some of them are real. We are seeing it in the clinic. The psychological effects of the atopic dermatitis also, we have to be very careful in such a case. So what is the treatment principle? Usually it's a ladder. We go like from the basic, and then we go to the topical steroid, and we go for the like phototherapy, then we can go for the systemic therapy. Sorry. So here we have some principle: moisturizing, emollient, optimal topical therapy, wet wrap therapy, and maintaining topical therapy, and systemic therapy. So I like this slide from other presentations. What it's explained for you, that there is a period that we have exacerbations or flare up, and that's what we call short term. We have to manage, and then we have long time. We have to in remission. That is, we have to control the symptoms, because sometimes there is no eczema per se, but there is an itching and dryness. So you have also to keep the patients on treatment even in the remission time. So moisturizer or emollient. Here we talk about, as you can see, we have to consider the cost, the accessibility, and tolerability of the emollient for the patient. We have to know, what does emollient or moisturizer mean? What is the difference between them? Like, we have the humectant moisturizer, we have the emollient moisturizer, we have occlusive moisturizer. And here I put each of them as an example and how it acts. Here, like a logarithm showing how we treat the eczema. So if the patients have like flare up now today, we come to the clinic, what to do to the patient? So number one, you have to educate the patient. You have to talk to him. You have to spend time with him. And then you have to start him with low corticosteroid on the affecting area only. And you will use it in a period of time, like 2 weeks, maximum 1 month. You will review the patient. If the patient is maintaining the result, that's fine. That means you have to keep him on emollients and intermittent use of the topical corticosteroid. If the patient is not getting better, what you have to do, either I have to make to go for higher potency of the topical steroid, or I can use other steroid sparing or other topical treatment of eczema. We will mention it. And then again to reassess the patient. So here about the optimizing the topical therapy, here we have to, as I told you, we use it at the period of 2 weeks. Initiate the treatment at the first sign of flare-up. So you will give these instructions for the patients, even for the next flare-up. If you see the patient having the symptoms, start using the treatment even before coming to the doctor. If you finish these 2 weeks, everything is fine, return the medications to the fridge or to cold place. So you have to continue the treatment until you have the complete or almost complete clearance of the skin lesions. And you have to apply the medication, especially the steroid, once per day rather than twice a day. Here we have something we call it fingertip unit. It's easy, and I'm usually explaining to my patients that how much they can apply of the corticosteroid for the eczema or the body surface area. Here, like example of the kind of corticosteroid, we have actually we have 7 potency, but in the practical we are using like 3 or 4, sorry, 4 and 5 potency. Again, you have to be very careful to the formality of the topical treatment. We have the creams, lotion, ointment, face gel. You have to know what does it mean, each of them. And if you have a plan to mix like antibiotic with the topical steroid, you have to know that you have to mix a cream with a cream or ointment with ointment. You cannot like mix a cream with ointment. This is in detail the types of the corticosteroid. So also, again, this is very important to explain the side effect of the topical corticosteroid, other steroid, that it can cause atrophy, tendency of bruising, burbera, stria, telangiectasia, hypertrichosis, maybe steroid acne, a rebound effect. Now, if the patient is not getting better, what to add? We can add for him wet wrap therapy, which is like you give the patient a wet wrap and then you cover it with another layer of the dry cloth, so the moist will be there. So you take them back. You ask the patient, the parent, to take the patient's bath and then to tap with a towel, apply a moisturizer, put a wet cloth, and then put a dry cloth, and then keep it like overnight. But if you will keep, for this technique, you will keep it like corticosteroid. We don't want like to be like systemic absorption of the steroid, so we minimize it for like 1 to 2 hours. But if it's only for moisturizing, you can keep it overnight. Another type of like behavior we can do for the eczema, which is the bleach bath, and I think it's worked very nice, especially if we have moderate severe. It will help us to treat the colonizations of the Staph aureus without any bacteria resistance. So I always tell my patients, open the, even you open the Google, just write bleach bath and you will see the regimen there. So what if I want to use the maintaining therapy or the steroid is not working? I have to go for something, we call it the tacrolimus or picrolimus, which is topical calcineurin inhibitor. It is steroid free. Usually we use it even at age of 3 months old, 3 months old. And it's really good because it have like stinging and burning sensations when you apply it. You can at the beginning mix it with the topical steroid, and after a week you can withdraw the steroid and continue on the calcineurin inhibitor. Usually in the maintaining therapy, we don't use it every day. We use it like 2 to 3 days a week, and we have to keep the emollient multiple times per day. Crisaprolol is the like a new, it's not a new, actually there is some newest medications, but this is also from the last like 5 years, let's say, and it will help us. You can use it at the age of 3 months of age. We can apply it twice a day, and it really helps us, and it's similar to the outcome of the potency steroid 6 and 7. This is a new in December 2024 approval for the eczema, which is the Tabinaroof. You can use it for the children 2 years old once daily. This is a very new and fresh FDA approval. I think it was last week only, because it was approved for the elder age, but last week they approved it for the 2 years of age. This is a topical JAK inhibitor. Honestly, I have experienced more for the vitiligo and alopecia, but I think I will introduce it now in my practice to the 2 years and above. So what if these topicals not working? What to do? So there is the number one systemic therapy that I can go for it, which is show safety and efficacy, is the dupilumab, Dupixent. It's approved from age of 6 months of age. If dupilumab is not working, then we can go for cyclosporin, methotrexate, or we can go for the phototherapy if the child is 6 years of age, or we can go for other biological, and we will discuss this very shortly here. So this is the phototherapy, UVB, UVA. Dupilumab is like interleukin-4 and 13 antagonist, and usually we use it from the age of 6 months. There is like 2 regimens we use it. Some people, they will go for the loading dose, some people will go for a non-loading dose, and according to the kg. What is the most side effect of the Dupixent is the conjunctivitis. So don't surprise if you see a patient treated on eczema and they have like perioral dermatitis or conjunctivitis. Another biological that is approved for atopic dermatitis, which is the tralokinumab, which is the Adapri. It's approved for the 12 years of age, so not till now, not for the younger age. And usually we use it at 300 milligrams subcutaneous initially, followed by 150 milligrams every other week. Another biological also approved for the adolescent age of 12 and above, lebrikizumab, and that's also, all of these 3, no laboratory test is needed, honestly, because it shows there is some safety. Not some, they are safe, but as I told you, the conjunctivitis are common side effects for all of these injections. Nemolizumab, it's like anti-itch medications. It will help us with the atopic dermatitis and other skin diseases that cause itching. And usually it's approved for the age of 12 and above. We have the JAK inhibitor. We have the Rinvoq or the abatacetinib. Usually, again, it's for the 12 age. Another aprocitenib, again for the 12 years and above. Paracetinib also, we use it for the age of the paracetinib, we use it for the lesser age, the 2 years. We give it also for alopecia areata, and it's worked very nice. So coming back to our patients, patient received Dupixent, which is dupilumab, and after 1 loading injections, she's like almost, I mean, nothing to mention. She have her Eid with happy vibes. So the one take-home message is the educating families about the expected diseases course and safety of the treatment can build therapeutic foundations of trust and understanding. And if you educate the patients, tell them how important the emollient, rather than just keep treating the flare-up with the steroid. Thank you so much. I think we reached the end of our lecture.
Thank you, Dr. Mariam. That was a comprehensive presentation on atopic dermatitis. We had the privilege of hearing you once before, and it was, again, a pleasure to listen to you. We will wait for the questions from our audience. In the meanwhile, while I scan through the chat questions, I will have you discuss amongst both of you. Dr. Devya, since this is a platform for practicing pediatricians, you did a very good presentation from various aspects you approach, right from one angle of etiology, the other angle of approach, other angle of dermatologist's perspective. So you can just give us an overview of what would be the dermatological emergencies one pediatrician should not miss when encountering in a triage fever with rash? uh, just go over them. That would be your take-home message for us. So I know it would be a repetition from your presentation, just to cumulatively approach our audience.
Yeah.
Thank you.
Yeah.
I will just go through the questions in the meanwhile. Yeah.
Yeah, thank you, Dr. Vanita. So for us, some dermatological emergencies, of course, and that we should not miss. One is if you look at, anything that that goes beyond the skin, okay, that has systemic features, okay. It may be fever, which is not going away, or it may be that the child is sick, there's hypotension, there's multi-organ failure, or there are presence of other systems, like there is joint pains or there is abdominal pain. Okay, see, fever with rash, most of the cases predominantly they would be self-limiting. It would be some viral exanthem or maybe a drug rash. Many of them are self-limiting. But when these red flag signs are there, then it means that you have to follow that lead, and you have to see, say, for example, abdominal pain. It could just be a Henoch-Schönlein purpura. Okay, so again, you have to uh, so one is the red flag sign, systemic symptoms, morphology. Okay, anything which is purpuric, petechial, hemorrhagic rashes. Okay, sick child. So those would be the red flag signs. Okay, and if you come to individual entities, and most of these children will actually not come to OPDs, they will come to your pediatric ER. Okay, so it would be SJS, TEN, drug hypersensitivity syndrome, staphylococcal scalded skin syndrome, serum sickness like reaction. Okay, these are some of the few. And then of course it could be vasculitis, it could be other purpura fulminans. There are so many.
Yes, doctor. Yeah, the key there is cross consultation. Of course, if there are systemic symptoms and signs, a pediatrician will be more aware of handling the systemic signs and symptoms. And when it's dermatology, of course, we would have a cross consult as you suggested. The challenge would be the drug exposure emergencies that the dermatologists would come, and we have encountered some. So I generally ask the dermatologists these questions whenever I encounter these. Do not have a timeline as exposure and then you get the rash. That would be somewhat chronologically informative to us. Most of these emergencies have a lag period, somewhat exposed. You should just have a keen insight that this would be possibly the drug, like the SJS and 10. And we had two cases of similar presentations of dress also. So these, the fever and rash, are the clues, and you can tell us about your input as to how to approach the dermatological emergencies of drug exposure, and any tips to pediatricians to handle.
Yeah, sure. So, so as I said, when you are looking at a drug-induced rash, some of them are fairly straightforward, like an SJS, TEN is fairly straightforward. Okay. The problem comes when you're looking at a maculopapular drug eruption or a DRESS or a DHS. Okay. That is when you are like, because broadly in my mind, I have it as either it's an infection or it is drug or it is connective tissue. Okay, so one thing is clinical pointers would be any kind of DRESS or drug hypersensitivity reaction. Typically the lag period would be about 4 weeks. Okay, always look into history whether there are any high risk drugs. Okay, any kind of aromatic anticonvulsants, something like Dapsone, Septran. Okay, some medications are very well known to cause DRESS. Okay, so if that is there, then that is a very, very strong pointer towards a DRESS or a DHS. The other thing is facial edema, generalized lymphadenopathy. Okay. And again, DHS or DRESS has multi-system involvement. Okay. And then there is this, you have this Japanese criteria, which is there. And then, you can just see, as I said, eosinophilia, if you do a biopsy, the skin biopsy often shows presence of eosinophils. So that can be a useful pointer. But in blood, eosinophilia is not always there. Sometimes in severe cases, you can even have an eosinopenia. Okay. But usually the diagnosis is based not just on any one feature, but it's a constellation of signs and symptoms and the history and the present. And many times you always ask for traditional and alternative systems of medicine like Ayurveda or homeopathy, because many times patients do take that simultaneously. So recently I had a patient who actually presented, who was taking this Ayurvedic medication for a very long time, who presented to us with acute pancreatitis. Okay, so never forget to ask, at least in our part of the country, we always ask whether that history is there. So those can be some pointers. Some other drug rashes, as I said, SGST, and they are fairly straightforward. A skin biopsy can help.
Okay, thank you, Doctor. There are some questions for Dr. Mariam about the steroid. One question, of course, you kind of covered it. One question is about steroids, intermittent steroids. When is that you would decide? Can intermittent steroid be given despite not having flare-ups? That is a maintenance, I guess. This is the question Dr. Reem Al-Arabi is asking. Can intermittent steroids? I assume this is about topical steroids, although that's not mentioned.
Yes, I think, you can do like intermittent steroids, especially in the remissions, once a week, twice a week, especially in the resistant plaque that that's it's there most of the time. Just now it like clears up, so you don't want it to get back, so you can do it. You apply the steroid intermittent two to three times, but usually I'm doing it once to twice a week on the spot only.
So can you guide the pediatricians onto how you would do the intermittent? When there are lesions, you know where to apply. When the lesions are not there and you're doing a maintenance plan on non-existent lesions, how would
but
you
you will keep it
plan
in
that?
you will apply it on the site where is like previously resistant to plaque. Like we know it's in the anticubical fossa, it's there, but now it's clear, but it's a resistant place. So we can keep it on the anticubical fossa and the area that it was there. So this is how we maintain the therapy. And usually for like maintenance, I'm trying not to use the steroid. Let us use the calcineurin inhibitors or emollient more. And sometimes we need to keep a steroid, honestly. Myself, if I want to make the steroid more or less potent, I try to mix it with the emollient itself or mix it with the skin barrier creams. That will help to make the steroid less potency and widely distributed. So intermittent course means that we can use the topical steroid in the place of the previous eczema plaque.
And how long would you do, depending on the course?
As I told you, if you have the flare up, you will do it every day, once a day, every day for like 2 weeks, and then wait and see. If it's still there, you can continue for 2 more weeks. After that, usually I'm doing like 5 days, 2 days off, 5 days, 2 days off, if it's not responding. If it's responding, then you have to stop using it like daily, and you use it like once a week, twice a week, with the continuations of the moisturizer. So the most important here is the moisturizer. Do the moisturizer like as much as the patients can do. Because if you tell them make twice, he will do one. But when you tell him whenever you can apply the moisturizer, then he will do it 2-3 times a day.
Okay, another question always pediatricians would want an answer from is, when would you want the pediatricians to refer to dermatologists on atopic dermatitis? It's a common presentation to us, and we all handle according to the instructions and the current updates and such. When would it be the time we should refer to you? And what's your experience as to these recalcitrant atopic dermatitis, and what are your go-to medications?
So if the first presentation is like body surface area is like more than like 10%, this is immediately you have to refer to dermatology. Another thing is if you give the patients the treatment for one visit and he come back, he's not responding, or he's respond very for like he flares up again after that time, again, you can refer him to the dermatology. If you are not confident that this is atopic dermatitis, you have to refer him to the dermatology. And some people, they will like, for me, most of the patients that come from general practitioners or from pediatrics, they will come with hydrocortisone, which is the lower potency of the steroid, because they have we call it steroid phobia of prescription. That also you can refer to the dermatology, so we can manage very well for this the group.
What would be your approach, like when it's not managed in the first approach? What would be your approach? What are the are you going for biologicals, and what are the experience? You
I will
showed one
wait.
of the biologicals, yeah.
Yeah, if as I told you, if the body surface area is a lot, I'll give a chance one more with my instructions. We'll see the patients how respond. If the patient is like not responding, then I will do for him the papers or the requested for the biological. But again, after coming for me, I will definitely increase the potency. I will alterate what topical he's using. If he's using, what is the instruction, what's giving, how many times. The most of our patients are concentrated on these steroid only in the flare up. They don't know how to, they are not aware of keep moisturizing. It will help, truly help them. So when they just like a little bit changing in their lifestyle, everything will change. This is the commonest comment. This is what we see mostly in the clinic, but there is like a really difficult case to treat.
Okay. Another common question we all get asked in the pediatric clinics is about the flare-ups because of food exposure, and then they have a random list of food that they have already eliminated. And for us, basic nutrition is our primary concern. So just give us an overview about this topic, if you can, and when would you suggest testing? Allergy testing, this is another random question we all get asked
It's
about.
giving you and us
we
headache.
Yeah, we discourage them and we say we probably are not looking at anything. Food allergy is not typically the thing that flares up, and then unless there is an historical flare up. So give us an overview of how we approach. After which, I have some more questions listed here, and Dr. Divya can give us an overview of atopic dermatitis management from her side, and I want an overview of biologicals so that we can counsel our patients and the expense and the availability in our parts of the world. Yeah.
Yeah. So regarding the diet, usually I'm telling my patients, eat whatever you want. Whatever you like, you eat. I'm not talking about the candy and the sweet. I'm talking about the normal food. Eat whatever you want, because if the patient, the only thing that I am afraid of is the type 1 hypersensitivity, which is the anaphylaxis. That is what I'm afraid of. Otherwise, any food allergy, with exposure, he will get tolerated very well. So even if I did for the patients, as they request like a food allergy, usually I'm not doing it, honestly. But I'm doing it if for like, as I told you, there is history of anaphylaxis or shocking or not getting shortness of breath, that I will do it. But like regularly or routine, I will never do it unless the patient is insisting. Because I'm telling, if I did for you and it shows that you have positive for the egg and you are eating egg and nothing happening clinically, why you should stop the egg? Why you are not getting the benefit of egg because only in the blood there is positive. If you have like, it's really annoying the baby, it's not sleeping, or in the extreme, we can like avoid the egg for now and then to re-expose it later on. And there is like a new study right now. Actually, they are with me, right? Yes, they are concerned about to introduce the peanuts, which is the one of the most allergen maybe component to a very early age regarding to the, and even if the patients have like atopic dermatitis, so try to expose the peanuts early so you can avoid the severe allergic reactions then after. So for me, as I told you, I am not prohibit any food from my patients. I let them eat healthy food. healthy lifestyle. And if the patient's having like, they are too young, I tell them, okay, just stop the food for now, for only like this month, 2 months, and then again reintroduce it for them. And slowly, he will get exposed to this food and he will be fine. But if the patient has like a type 1 hypersensitivity or anaphylaxis to that food, that definitely will not be, I will not take a challenge on that.
Like any other child, if there is any suggestions of urticaria and anaphylaxis, that probably would be an indication. Or
Yes.
probably along with other comorbid allergy manifestations like asthma, and it's difficult to treat, probably it would be useful to
Yes.
get an allergy testing to inform us.
Yes.
Thank you.
Yeah.
There are some questions. What would you do with the hypopigmentation after application of steroids? How would you approach?
I will, number one, I tell the patients to minimize the steroid and I will replace it with the calcineurin inhibitor. Usually these pigmentations will come back. But if the patient is like because they are most likely hypopigmented rather than depigmented. So usually it will come back. But with the use of calcineurin inhibitor, it will help to the color to come back and to treat the condition.
Okay. No specific treatment as such for
No,
hypopigmentation?
because also calcineurin inhibitor, we treat the vitiligo with it. So so the mechanism is the same, the reductions of the melanocyte on that side, and usually that's because of the medication. So if we stop the medications, with the time it will be better. And usually
Okay.
the eczema itself, even without using the steroid, can give us the like residual hypopigmentations or hyperpigmentations. This is well known. Post-inflammatory hypopigmentation, post-inflammatory hyperpigmentations. So that also I have to explain to the patients. So they don't have like steroid phobia in the future.
Yeah, steroid phobia is another concept we have to conquer in our clinics.
Yeah.
Yeah, some doctors are asking, Dr. Aparajita, this was Dr. Samara's question. So Dr. Aparajita is asking, can you give points to differentiate diaper rash, which could be manifestation of atopic dermatitis as well, differentiated from the fungal infection? How to differentiate hypopigmentation in the neck creases in infant?
Okay, I think this is a lecture by itself.
Exactly. It seems like, okay, if it
Yeah.
is an atopic or a fungal, some pointers if you have.
See, fungal, usually you will see satellite, if I'm talking about the candida, you will see the satellite lesions very clear. You will see papules or plaques with the satellite lesions, red, puffy red, this is like candida. Allergic contact dermatitis, you will see some erosions, you will see some itching. And as I told you, atopic dermatitis per se in the diaper area at age of infancy, very less likely.
Yeah, so if you find a rash in the diaper area, you would rather take it as a negative thing for
Yes.
atopic dermatitis.
Yes.
Okay. Okay, that was informative. Can Dr. Divya give an overview when we come back to Dr. Mariam about the biologicals? Dr. Divya, your experience and if you can share some insights about atopic dermatitis.
Yeah, so we see a lot of atopic dermatitis here, and I see a lot of it in my practice. Almost 70 to 75% of my pediatric derm practice is either atopic dermatitis or eczema, childhood eczema of some form. And invariably, you can trace it back to atopic dermatitis. So I think Dr. Mariam has done a very wonderful job in sort of taking us through how to diagnose and treat, and I kind of concur on all her steps. And some things that I just want to share is that in my practice, I use a lot of wet trap therapy, especially as a bridge between, especially when you have these moderately severe cases where the topicals are not working, but you're not sure whether to start on systemic therapy or you're not very keen on starting systemic therapy. Then what I do is I do an emollient only wet trap therapy. Okay, so just give a plain water bath to the child in the evening, followed by full body application of emollient. Okay, followed by, if the child has active rashes, then steroid only on the area of the rashes. And then in India, what we do is we tell them to wear like a fitting jumpsuit, okay, as the inner damp layer, and the outer layer has to be a dry kurta pajama. And even half an hour or 45 minutes of that, okay, I have seen that sometimes it makes the skin very smooth and soft and supple. Okay, that is one thing. The other thing is, again, moderate to severe atopic dermatitis, not responding to topicals alone, then staph decolonization is something I do routinely. So staph decolonization, either by mucosan prophylaxis or by bleach bath, along with wet trap therapy, ends up controlling even another 20 to 30% of the cases. And then what I also do is proactive therapy. That was one of the questions I think which was asked. That's a topical steroid 2 days a week. Either you can do it as a weekend therapy, that is Saturday, Sunday, or I do it like a midweek and end of the week. Okay, even when the rash is not there. So apparently normal appearing areas of the skin, but areas which are prone for flares like your cubital fossa, popliteal fossa, neck folds, because I tell my patients that the memory T cells are still there, so the rash can come back. And a course of that maybe 3 months or 4 months, and then even if the patient say doesn't respond to that. So unfortunately in India, we don't have dupilumab available yet. So here the treatment of the first line of choice for acute flare is cyclosporin. So that's what I start. And then a rapid taper, and then maintain again either on topicals or probably, some other alternative immunosuppressive agent.
Okay, what's the timeline of cyclosporin?
So
how soon is the response, and how long would be the?
Yeah, so response is very quick. Okay, so you would see response, so 3 to 5 milligram per kg, you would see response within 2 to 3 weeks, and then start tapering by around 0.5 to 1 mg per kg every 3 weeks. And then the problem happens in the really severe cases. The moment you're judging 0.5 or go less than that, or 0.25 or 0.1, and then that's when it starts flaring up again. Okay, so as much as possible, I do not give cyclosporin for more than 6 months. Okay, even though guidelines say that you can give it up to a year or 2 years based on European or American guidelines, I usually do not give it for more than 6 months.
When we have achieved tapering to that extent, can we top up steroids and go back to the management like before?
Yeah, so I mean, off late, I usually do not use oral steroids. I hardly use oral steroids for a severe.
And the topical steroid, like
topical steroids have to continue. That has to continue.
Yeah. Okay. Okay. Okay, Dr. Mariam, what's the status of your practice of biologicals, and how expensive, and what's the availability in Bahrain?
It's in Bahrain it's available, but not all the time. Dupixent is available, and actually, if the patients would like to have the biological on his own expenses, it will cost like, I'm not sure, about maybe around $1,000, little bit more, $1,000 per month, or maybe a little bit more. I'm not sure, but between 1,000 to $500,000. Again, it's something, because you have to continue at least for first 6 months. You have to be sure that patients can pay for it, or you can send it for the governmental hospital so they can afford it for him.
It's the interleukin category.
Yeah. So I have
And the JAK also?
The JAK inhibitor also, actually, we have the Rinvoq in Bahrain, but as I told you, Rinvoq is for 12 years of age. So before that, I cannot give them Rinvoq. So I have only one option. And I think the Dupixent will be the safest option for like 6 months of age, if that's severe. And yeah, I think the patient should be, the family should be aware how to use it, where to store it. So these things also to be discussed with the patient's parents.
Okay, so your experience is also with cyclosporin more?
Yeah, usually I have experience with the cyclosporin in adults more than the pediatric age group, honestly. And I think the good thing is that it's work fast, it works nice, but because of the side effects, we are limiting the use of it. For the baby that you have to do for him blood withdrawal every like 1 month to check the renal function. I think it's like, I cannot do that for my patients, honestly. So I think I prefer to go for the safest.
That's our job.
As a pediatrician, as a dermatologist. Yeah.
Yeah. Okay. So I gather that's the picture as of the practice in our parts of the world. Okay, so can we summarize one take-home message each of you can give from your topic before we wind up?
Diva will start or I will start?
Dr. Devya.
Yeah.
Okay. Yeah. So my take-home message would be, if you are dealing with a case of fever with rash, um, you know, I think cross consultations are very important. As dermatologists, we never ignore any red flag signs, any systemic symptoms. We always bring pediatricians on board. And for pediatricians, I think if you have any doubts about the morphology, then always involve the dermatologist, because some side lab test, a zank, a skin biopsy, okay, or even looking at the morphology and distribution can give you a lot of clues for the diagnosis.
Point taken, Dr. Maria.
For me, as I mentioned in my slide, if you have patients with atopic dermatitis, take time with them, sit with them, explain for the parents about the disease itself, because you will really help the family. Yeah, the disease is in one kid, but the problem is in the whole house. Lack of sleep, lots of crying, irritated baby is not easy at all. So sit with them, talk to them, explain for them everything. Don't let them go outside from your clinic unless if they have any concern. Just explain everything for them.
Thank you. There are lots of appreciations and thank yous from the audience. It's
Thank
available
you
for
so
you
much,
to
Benita,
go through the
and
chat.
all
Yeah.
the audience. Thank you so much.
Thank you. Thank you so much.
Thank you, Dr. Devya and Dr. Maria. It was indeed a great discussion today. And the audience, until next time, the fourth Sunday, the next month, we'll catch up with the next topic. That would be hematology, pediatric hematology. Thank you and bye.
Bye. Good night.
Bye-bye. See you.
Good night. Let's sign off. Bye-bye.
Bye-bye.